Alright, so this is a training video for the pediatric needle cricothyrotomy. Below the age of 10, in some textbooks 8, we don't do a direct surgical cricothyrotomy because of the nature of the pediatric airway and the fact that the narrowest point is around the cricothyroid cartilage. So we tend to do a needle cricothyrostomy as a backup for the can't intubate, can't ventilate, can't oxygenate scenario. A couple of key points: it oxygenates, but it does not ventilate, because all you're doing is filling the lungs up. I'm going to go through the technique, but you fill the lungs up with oxygen, but there is no respiration or ventilation, so CO2 is not being vented. So you've got about 30 minutes. CO2 rises in the apneic person at about 3 millimeters mercury per minute. So if you think your normal CO2 is 40, you think about going up to 100 within about 20 minutes. You know, it's got to rise 60, it goes 60 millimeters, it goes up 3 per minute, so you've got about 20 minutes. You can certainly become more hypercapnic than that. So that's why we say about half an hour. It is a temporizing measure only. You need a definitive airway at some point. That's for another video. Just going through the equipment. This is a standard kit in our airway trolley, okay, and it actually comes with instructions, and I'm going to basically read the instructions, not word for word, but I've already read them to make sure that I get this video right. But it comes in a bag. We've got the bag over here, a little bit of gauze, the instructions on the front, all the tubing and everything is within the bag, and if you're ever worried, you just get it out, put it on the airway trolley, ready to go. Okay, it is all set up, but obviously I'm going to describe what needs to be set up for completeness. Alright, so what we have is we have a 16 gauge cannula which is not opened, and a 14 gauge cannula which is opened, and that's what I'm going to use. Okay, basically the 14 gauge cannula is for children above the age of 1, and the 16 gauge cannula is for infants and babies less than the age of 1. Obviously size difference, and we've actually got the extra long 14 gauge cannula as well, just for safety, make sure we get it in properly. Alright, we've got a syringe, okay, which we will use on the end of the cannula to aspirate as we go in, so we know we're in the right spot. Obviously, a little bit of skin cleansing, look, might as well. It doesn't take that long, it's actually in the kit. And then we've got oxygen tubing with a 3-way tap. Okay, so first of all, the oxygen is connected to the wall, and you turn it up to maximum. And there's a little bit of space between 15 litres per minute and the top of the dial. The reality is, if you dial it right up to the top of the dial, you can get 30, 40, 50, 60 litres per minute, depending on the regulator and depending on the pressure of the supply. Okay, what we've done is we've rammed a 3-way tap into the other end. We've left the cap on, you know, for cleanliness. Obviously remove that when we connect it. But the most important thing is that the tap, all 3 taps are set to open. And I'll go through why that is in a minute. In the kit that we have ready to go, we've got it taped so that no mistakes can be made. Okay, the reason that it's open is so that the side port's always open. When you're running oxygen at 15 litres plus per minute, 30 litres per minute, obviously when you've got a 6 kilo, baby, you need to let the pressure off, and so that's what the side pressure is. The lungs will fill up, you'll get a little bit of extra pressure, and then whatever blows out comes out the side port. So there's no, that lessens the risk of barotrauma, pneumothorax, that kind of stuff. Doesn't limit it, doesn't eliminate it. Barotrauma is a thing where whatever you do, whether it's just a simple intubation or bag mask ventilation, but certainly you've got the side port which always needs to be open. When we ventilate, because we're not ventilating the child, but obviously we're putting a little bit more oxygen in for a second and then letting it off to sort of improve the oxygenation and sort of ventilate and circulate air within the large airways in the lungs. We're going to put our finger on the tap for a second and then leave it off for 4 seconds. So that gives you 12 breaths, and they're not breaths, we're not ventilating the patient, but 12 breaths per minute. On for 1 second, off for 4 seconds. Okay, that's the reason we set up. The side port is always open so we don't get barotrauma, and 15 litres of oxygen can go out the side if it's not going into the chest, but it also gives it the ability to sort of entrain air through into the lungs, temporarily, and then for the lungs to blow off the pressure. Okay, so that's basically it. So no need for incisions, no scalpels, no forceps. Remember that you're not going to be able to secure this really, and you shouldn't think about securing it. Shouldn't talk about securing it, you just hold it. Because regardless, it's a cannula. Yeah, you might be able to tape it, but it'll kink, okay, at the drop of a hat. You can suture it, but don't, because it'll kink, it'll move, it'll whatever. You basically need to be holding it there, have someone there 30 seconds. They're going to be here with the tap anyway, so it's not really that big a deal, but for 30 minutes, they'll need to be holding it until you get the definitive airway. And that might mean walking next to the patient on the way to theatres, if they're going to do a intubation in theatres with all their special equipment. Okay, so the technique, obviously you've got the option of cleaning the skin. If you forget, I think it's going to be okay, to be honest, but it's there. I won't demonstrate that, obviously. We're going to palpate, and obviously we'll palpate then clean if you're going to take the effort. But you've got cricoid there, thyroid there, cricoid cartilage there. In the infant, might not be very well defined, so you sort of, bit of a educated confidence guess. As long as the cannula goes in the trachea, I think we're comfortable with that. Okay, so we've got the syringe connected onto the end of the cannula. Okay, so that we can actually aspirate air as we go in. It's all in the instructions. I've got the instructions here just to double check, because that's what you're going to be doing when you do this. You're going to have the instructions there just so you know all the steps. Going at about a 45-degree angle. Okay, we go in, and obviously this is a greater than 1-year-old child, probably. Go in, and we've got air. Okay, and then like you're doing bloods, quite straightforward. Once you've got air, you're in the right spot. You just bang the cannula in. All right. Always hold the cannula. You've got a dirty needle there. All right. So you're going to connect this up. Never let go of the cannula. Okay, you can see it's a pretty straightforward single person technique. And then you've already connected the oxygen, you're now oxygenating the patient. Okay, and then side port, 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And you will get tired of counting out loud for the next 30 minutes, so you're probably going to do it in your head. But that's what we're doing. And you're going to be here, you're not going to let go of the cannula. You're going to have your hand resting on the chest, because obviously the neck is not that long. You're going to have your hand resting on the chest, not leaning, but obviously just resting as a stability, and everything happens around you because you are now the most important, second most important person in the room after the patient, obviously. But that's basically about it. You'll have one hand there doing the tube. The tube obviously goes off to the sides, and then everything else happens around you. All right. Well, thank you very much. As I said, the kit is in the trolley, the instructions are in the trolley, it's all set up, ready to go. This is something you can just get out the kit and perform it within about 10 seconds. So good luck.